Thank you very much. And once again, I'm very happy to be here, and I'm grateful that the organizers have had invited me to come here and speak. So today I'm covering a topic which is quite close to my heart, and that's to do with how, if one has autism spectrum disorder, how it can actually affect the diagnosis of other conditions, and also in terms of some of the rare diseases which can mimic psychiatric conditions as well as have difficulties as a consequence of that. These are the conflicts of interest, and so if we are looking at an assessment for autism spectrum disorder, you have to have the social communication deficits, and then you have the restricted interests, repetitive behaviors, and so on. But what also has to be done at the same time is to understand that you can have genetic conditions that contribute to this in the first place. So it could be things like Fragile X, tuberous sclerosis, Rett syndrome, and other conditions. But most importantly, you also have to assess intellectual ability, so the language skills, adaptive functioning, because you can have the lens through which a person with ASD functions is because of how much is their intellectual ability. You can have from severe intellectual disability to superior intelligence. You have language skills where you can have hardly any speech to being fluent in speech. In fact, you can have hyperlexia, that is, you can actually read and spell much better than you understand. And you also have adaptive functioning, where you have individuals who need significant support versus someone who can be completely independent. So, therefore, just saying that this diagnosis of ASD doesn't mean much, because they are very, very heterogeneous, because you have all these other things to consider. Apart from that, you also have physical conditions that can coexist, things like epilepsy, gastrointestinal difficulties, immune and allergies, and so on. But the other condition that is important to consider is motor coordination difficulties. In fact, it is around 40 times more likely that someone has an ASD diagnosis if they have true motor coordination difficulties in the context of a very young child who has ADHD. So the thing is that if you've got someone who's got ADHD and they've got motor coordination disorder, developmental motor coordination disorder on top of that, the likelihood of that person having ASD is extraordinarily high. So for someone who's running an ADHD clinic, if you find that there's true motor coordination difficulties, then please do evaluate to see whether that child also has ASD. Because the correlation between the motor coordination difficulties and ASD in the context of someone who's got ADHD is extraordinarily high. Apart from that, you have the psychosocial stressors, especially when you move from primary school into secondary school, which is roughly around age 10, 11, and so on, or when puberty is kicking in. Bullying is very, very common in school, and that's because of the fact that the social skills needed as you grow older is much more complicated and complex than when you're much younger. So therefore, that particular issue with bullying occurring in the context of school and so on, and you can have exploitation as well, because they're much more vulnerable, and because of vulnerability, exploitation can happen, and the individual may not even know that they're being exploited. So the exploitation can be financial, sexual, physical, and so on and so forth. So these are all things to be considered. And then on top of that, as was discussed yesterday, and I think comorbidity is very, very common, and it's the theme of the conference itself. If you miss comorbidities, you're going to end up not being able to treat the patient well. So you have both externalizing conditions like ADHD, oppositional defiant disorder, developmental mood dysregulation disorder, and so on, or you've got the internalizing ones, which is such as generalized anxiety disorder, depression, OCD, and so on and so forth. But also there's a growing evidence there's an increased likelihood of catatonic presentations in ASD, and so that I will touch upon that as we go along. So you can see that just doing an assessment for ASD, it does not mean that you just do the ADOS and you actually do some tick boxes and say that someone has got ASD or not. You need to be able to profile the individual, because all of this is important when one is actually trying to do to treat or manage the patient. So when you're looking at multimorbidity in the context of ASD, there's language problems, motor coordination difficulties, I've already mentioned. Epilepsy is common, especially if you've got a genetic underpinning to the ASD. You have very high likelihood of spasticity and dystonia, gastroesophageal reflux, constipation is common in ASD, and you can have metabolic syndrome and cardiac abnormalities and so on. And the more number of medicines you're on, the more likely you are to end up having more side effects as well. Now, these conditions here in light blue, that's ADHD, oppositional defiant disorder, anxiety, emotional autonomic dysregulation, depression, and so on, these are all treatable conditions, and so they need to be evaluated appropriately. The most important aspect of this is that when it comes to depression, there's a 9-fold increase in completed suicides during adolescence, especially in the high-functioning individuals with ASD. So therefore, what you really have to understand is that when you're evaluating someone with ASD for depression, do not actually just look at the facial expressions of the individual and decide that person is not depressed, because it can be catastrophic sometimes, because the person may tell you that I'm feeling sad and miserable and I'm suicidal, but he's sitting and giggling in the room, and so you'll think that the person cannot be depressed. And so therefore, that's really an issue. So in terms of the other aspect of it, in terms of psychosis, again, I will have a few more slides on that. Alexithymia is an increasingly recognized issue in ASD, which basically means that they are unable to actually experience and quantify or discuss about the emotional states and experience it. And this is very, very important, because you can end up having treatment failures being considered as treatment failures because the person is not able to experience the shift in mood. So you may have an ASD individual with depression or anxiety. They have been treated and their symptoms have got better. Everyone else can see that it's got better. But because of alexithymia, the person themselves cannot experience the change in mood. And therefore, they will tell you that I have not got better at all. And so it's a black or white scenario. So they said, I'm either unwell or I'm completely better. And so the middles in terms of the gray is very difficult. And so therefore, that is something that we have to really work on. Now, apart from that, the ones in the white in the middle, these are all conditions that have been increasingly recognized now. So eating disorders, especially in girls, 30% of every unit in the UK, and I'm sure it's globally, where for restricted eating, so anorexia and so on, 30%, 1 in 3 individuals have got undiagnosed or diagnosed ASD. So it is a very, very common comorbidity, especially in girls. Then the second thing, then the other increasing recognition is that these individuals are occupying medical beds with medically unexplained physical symptoms or MUPS. So these are individuals who have aches and pains or some physical symptom, and so they are admitted into hospitals and they are being investigated multiple times to see what the problem is. And that's again related to the ASD, because they are unable to express themselves, and so they somatize quite a bit. So that is another new area where increasingly it is becoming clear that you need professionals who can actually understand ASD when you're actually dealing with MUPS. Then, of course, you've got dissociation and conversion happening, especially this is to do with pseudoseizures, things like that, sudden loss of function, where it's a mechanism of coping when they're suddenly ended up with stress and are unable to cope and don't know what to do. In a very primitive way, it is they've got primitive defense mechanisms to deal with, and so therefore they are actually coping as it would have been around 40 to 50 years ago in the general population. And of course, then the last thing which I do want to highlight is that the increasing number of individuals declaring themselves to be having gender identity disorder or recognizing themselves as transsexuals have increased dramatically in this population. In fact, the Gender Identity Clinic in the UK, roughly their numbers show roughly a third of all individuals coming into that service has got ASD. So either diagnosed or undiagnosed. So again, it is a huge issue at the moment, and in the West, at least in the UK. And so we've ended up having to reorganize the whole services for individuals with gender identity disorder, because their understanding of gender, their understanding of sexuality and so on is very different, because they have very poor peer interactions, and so it requires much more complex assessments to be able to be certain that they've got the condition. So what are the issues to do with ASD itself? First of all, they have very abnormal response to pain. Often you will end up, the family is telling you that he fell down, he almost fractured himself, but he's still not crying, or he's not really making a big fuss about it. So that again is important to understand, especially when you're looking at long-term consequences, because that has an impact in terms of safety of the child. Then, of course, the sensory issues, you can either have hyposensitivity or you can have hypersensitivity. Again, that leads to in terms of sensory stimuli, again leads to very different consequences. And again, in terms of the synchronization of motor responses is very unusual in ASD. So, for example, there are some artificial intelligence algorithms now looking at how a person walks and can make a diagnosis quite accurately that the person may be on the spectrum. And that's because of the coordination of how the person moves when they're actually intentionally moving to something. So the other aspect which has to be considered is the issue around individuals on the spectrum often have imaginary friends, because imaginary friends are much more predictable than human beings. Because human beings, you may see someone and you say hello, the person may smile and say hello to you one day. The next day you say the same thing and the person might ignore you because the person is lost in thought. And the person just does not know. So one of the biggest problems in ASD is the inability to manage unpredictability. If it's predictable, everything is predictable, ASD is better managed. However, life is not very predictable, and so that's how they end up developing imaginary friends, and these imaginary friends can then wrongly be construed as being psychotic symptoms, especially as they grow older. So it's a very important thing to take into account the issues around when did the symptoms start, what needs to happen, and so on and so forth. Hello, can you hear me? Can you hear me now? Okay, sorry about that. I wasn't aware of it. And of course, the other issue then is to do with the abnormal thought organization and the way you speak. Uh, so, is this, can everyone hear at the moment? Or, okay. Uh, so, the issue is that you can end up having abnormal facial display of emotions. So, often you have inappropriate affect. So, the person may be severely depressed, might actually be telling you, I am depressed, I feel like killing myself, but the person might be smiling sitting in front of you. And this dissonance between facial display of emotions and what they're experiencing inside is one of the critical problems that professionals have, because they can often jump to the wrong conclusion that the person is having an inappropriate affect and therefore has got psychosis. But actually, it's a fundamental component of core issue with ASD is the lack of synchronization between affect display and affect experience. So their emotional experience. So that again is something that has to be taken into account. And of course, the way they speak, they can have stereotypic methods of speech and may actually need to involve their special interest in their talk. And so again, this can be wrongly construed as being pre-psychotic or psychotic symptoms, and therefore often individuals with ASD get wrongly labeled as being schizophrenic and end up being treated in hospitals with very high doses of antipsychotics with very little improvement, because obviously they're not going to respond. And oftentimes they are actually depressed and with psychotic symptoms, if anything, and they need an antidepressant, if at all any medicine has to be prescribed. So again, in terms of affect recognition, for the person with ASD, they find it difficult to understand what the affect is, the emotion they're experiencing themselves and what someone else is experiencing. They find it difficult to label emotions per se. And of course, in terms of when it comes to in a clinic setting, when you're asking about how bad the mood is, how unhappy you are, and you ask, is it mild, moderate, or severe, they find it difficult to understand the constructs of mild, moderate, severe. So it's much more useful to actually say on a scale of 0 to 10, where 0 is not having any sadness at all, and 10 is the most sad you've ever been. And then ask them to give a number as to how sad they feel today. And they will be able to say, and very typically they will tell you it's 7.2 or 8.3, and no one else will do that other than they will usually be talking about it in whole numbers, but these individuals will give you even to the point, to the level of decimals. So use that as a thing, or use a visual analog scale when you're assessing it. And then, of course, if you are trying to explain to them what the affect is, what you're trying to get at, remember that at least 40 to 50% of them may just simply echo the descriptions you've just asked them about. So do not assume that what they're telling you is the same thing that they're experiencing. So you need to be able to explain to them whatever it is before, and then ask the questions much later, because otherwise you're going to just get a parroting. So when it comes to depression, how do you make a diagnosis of depression in ASD, which is very, very commonly missed? In fact, it is the commonest reason why there's completed suicide in adolescents currently in the Western world, because they are wrongly misdiagnosed as just having ASD, and depression is not picked up. So focus on the behavioral symptoms, focus on the biological symptoms of sleep, appetite, and so on. Identify whether they are still able to enjoy pleasurable activities for the same duration as they used to. So for example, if they were playing with Lego toys for around 3 to 4 hours a day, find out how many hours do they play with Lego toys now. And they'll tell you he doesn't even play for more than 20 minutes these days, but previously used to play for 3 to 4 hours. Now that's an indication that this person may actually be having, has lost the ability to enjoy pleasurable activities. And then of course, assess risk based on what the person is telling you, not based on what the person looks like. Because oftentimes they will tell you, in fact, the multiple times I've had to be involved in investigations and so on, where there's been a death, where there's suicide, but that has occurred even after having been seen by a medical professional, because the medical professional has not been able to pick up depression, because the person has been sitting there and telling them everything, that they're sad and depressed, but they're smiling. And because of that, the professional thinks this can't really be true, this can't be very serious even if they're depressed, and so then therefore they miss it as such. So now moving on to ASD and psychosis and catatonia. Recently I was involved in doing this systematic review and meta-analysis, which we specifically looked at what were the issues that made individuals with ASD more likely to have psychosis or catatonia, and what is the incidence of it. So first of all, right through from Canna onwards, there's been this whole thing about interplay between what do they call it, is it ASD, is it psychosis, and so on and so forth. But meta-analysis in 2018 showed that if you had ASD, you had a risk, having ASD is a risk factor for developing psychosis along your lifetime by around 1.5% or so. Odds ratio is 1.5. But the thing is that when we individuals with ASD are specifically looked at in terms of how you characterize what is it that you're looking for in terms of psychosis, it's much higher. So the whole concept of clinical high risk for psychosis, or CHRP, is defined as a status that confers high but not inevitable risk of developing psychosis. And so that means that the CHRP is what we focused on to identify whether there was a relationship between ASD and CHRP and what was the percentage that actually ended up with psychosis in the end. CHRP can be evaluated using these questionnaires, such as the structured interview for prodromal syndromes or the CALMS. So when it comes to clinical high risk for psychosis, it includes the presence of subthreshold positive psychotic symptoms, the presence of an episode of a frank psychotic symptoms, but it disappears spontaneously within a week, a presence of significant deterioration of function which lasts for around a month, but was present in the last 12 months, but there's a family history. And then there's also this thing about the subclinical disturbance in mental processes such as stress tolerance, affect, thinking, speech, and so on, and vegetative symptoms. And that is where a lot of the patients end up with ASD can get wrongly identified as being psychotic. So, as I highlighted about affect, there's also a problem in there's social interactions and affect. There's unusual thought content because the person may be thinking about dinosaurs and Mars or whatever, and that can then suddenly get misconstrued as being psychotic. They can have stereotypic behaviors and rituals, which can again be considered as psychotic symptoms. So there's many of the symptoms can be overlapping, and therefore you can wrongly get diagnosed as such. So this meta-analysis which we looked at, it contained more than 11,000 subjects who had been assessed for CHRP, and what it showed was that the odds ratio is that in those with it's 5.5% of them, of those with CHRP, had a diagnosis of ASD. And what you have to remember is that this is extraordinarily high because most of the studies had excluded ASD in them, in their cohorts. What is really striking is that most of them were male, they were young in adolescence, and when it was a female with ASD, they had more positive symptoms and they had significant impairment in structural pragmatic language, social cognition, and poor global functioning, none of which is unusual because of the ASD itself. So, coming to catatonia. Catatonia is where you have a problem in motor and volition impairment, where the main features, you can have social indifference, you can have mannerisms and stereotypies and echolalia and so on, and some underpinning the GABAergic mechanisms have been considered, and there are some susceptibility genes that have been identified for both ASD as well as catatonia on the long arm of chromosome 15. And the meta-analysis, what it basically concludes, this shows you the various studies and where they lie. 0 is no contribution. Anything to the right is that ASD is more likely to be associated with catatonia. And so the bottom line is that it showed that 10.4% of individuals with ASD have catatonic presentations. So that's quite 1 in 10 is not a small number. It's quite a large number. But of that, if you had an ASD diagnosis and you had catatonia, almost 90% of them were males, and they seem to be more predominantly those who had speech problems as well as motor problems. So starting with thing was that rare diseases. And so, first of all, I want to highlight that though we talk about rare diseases as being rare, 1 in 17 people in the world have got a rare disease. There are 400 million people living currently with rare diseases. There are greater than 7,000 different rare diseases. 75% of them affect children. 30% of them never reach their 5th birthday. So on average, it takes 5 years to get to a diagnosis, and this is global impressions, and these are all facts, these are all numbers. So in fact, the rare disease foundations will tell you that if all the individuals with rare diseases were put together into one nation, they would be the 3rd largest nation in the world. So rare diseases are not rare if you take all rare diseases together. So that's the backdrop in terms of why we are focusing on these conditions. So again, rare diseases will have an impact in terms of where the effect occurs. So this is prenatally where the brain is developing, and postnatally how the brain develops. These are all the things, activities that happen in terms of axonal or dendritic overgrowth, myelination, and so on. And you can see synaptic pruning and myelination continues into, can go on to be affected right through to adolescence. So therefore, depending on where problems arise, which part of your development, the kind of problems that the child will have will be different. So what are the causes for symptoms, neuropsychiatric symptoms, if you've got a rare disease? One could be that it's the brain pathology itself. If you've got many rare diseases have the brain itself involved, so therefore you can end up having problems. If the prefrontal cortex is involved, it's not surprising that you'll have executive dysfunction, ADHD-like symptoms, and so on and so forth. The second thing is that you can have hormonal imbalance. So any of the rare diseases that involve the midline structures, so for example, septoptic dysplasia involves the midline structures of the brain. So therefore, you end up with diabetes, you can end up with hypothyroidism, pituitarism, and so on and so forth. Then you've got issues to do with the sensory deficits and dysregulation. So many of them can have impaired hearing, impaired vision, and so on. That itself can lead to difficulties. Of course, because many of them can look dysmorphic because of rare diseases, that can lead to secondary issues, psychological issues, body image, impact on family, and so on and so forth. Of course, then intellectual disability and physiological consequences of the disease itself, because rare diseases are by definition multi-systemic. So the heart could be involved, the liver could be involved, and so on and so forth. So the important thing is that often when it comes to behavioral management, families find it very difficult to do because they feel guilty that they have given the genes contributed genetically to the condition itself. So therefore, it becomes much more difficult and you need much more expertise to be able to manage the psychological consequences. So if you're looking at rare diseases, you've got all these conditions that you can actually manage, just like I've mentioned in the ASD aspects. So this is a paper that I came across yesterday, and I'm not really sure about the people involved, but the two graphs are, it tells you where most of the research is being done in rare disease, and it says the first one is Cairo and the Cairo University, and then there's, I think it's Al-Sham, and then and so there are, yeah, so basically it tells you where most of the research is being done. And the kind of rare diseases that are involved, the majority of them are actually involving neurodevelopmental issues. And then you can see that there are to do with the neurological and so on and so forth. So the reason I wanted to highlight this is that recently in Egypt, you've got the screening at birth, which actually is where there's a screening for 22 diseases, and I've already highlighted it there. And most of these conditions, if identified quickly and you initiate some form of nutritional changes, the impairment can actually be reduced compared to what would have happened even 10 years ago. Now, coming to the Middle East, there was a report from the Economist Intelligence Unit in 2021, where they looked at the whole region, including the UAE and other countries there. And what was very clear is that because of consanguineous marriages, the likelihood of rare diseases was high. As most of the region's population was under 30, and therefore there's a need for cascade testing. If you identify someone being positive at birth, then you automatically have to cascade the testing to the whole family and relatives, because an example was given in there where one child was identified with Niemann-Pick type C, and when they did the cascade testing in Saudi Arabia, they actually found from a total population of 500 to 700 living in that village, 1 in 3 of them had the condition. So you can see that you need to be able to look at these things and identify and try and manage it. And of course, you need a collaborative approach, because it's not going to be easy when it comes to managing these individuals. So in terms of how can you differentiate psychosis, especially organic psychosis? So you're in a A&E, you're coming with someone's presenting to you with psychosis. How do you, what should you look for where you have to rule out a rare disease? First of all, if there is disorientation, impaired consciousness, visual hallucinations, tactile hallucinations, elementary hallucinations, the fluctuations in arousal, all of this should alert you that you may be dealing with a rare disease. Catatonic symptoms are very, very common in rare diseases. So again, it's another thing. Then remember that in rare diseases, often you've got multiple systems being involved. So if you are able to identify that someone's got organomegaly, you just examine the tummy, and you find that there's hepatosplenomegaly, instantly you know that there's a very good likelihood that there's a storage disorder like mucopolysaccharidosis that could actually be associated with this condition. And of course, when you start treatment and it actually produces worsening, and one very specific issue is if you started sodium valproate and someone ended up becoming extraordinarily unwell, then those individuals are often likely to have a urea cycle disorder. And so you need to be looking at it as such. So these are the telltale signs. Important thing is to recognize that it can be acute onset, it can be delayed onset. There's no specific differences because there are wide variety of rare diseases. Use very small dosages, and genetic counseling is crucial. This is just to say that there are different kinds of conditions which are common. So you have the leukoencephalopathies, you've got the mitochondrial disorders, you've got the mucopolysaccharidosis. These are all rare diseases which are seen in children. If you look at inborn errors of metabolism, this is very important because it's very common in this part of the world. You have 3 groups by which they can present. One is they can present to you as an emergency. And emergencies are when they have been relatively well, it's an acute onset, but it can happen repeatedly. And usually the conditions that they come to you like this is porphyrias. So if you've got acute intermittent porphyria, you can come as hypomanic, and or psychotic, or having a panic attack, and so on. Homocysteine remethylation defects, that's the homocystinuria, can again present like this. Urea cycle disorders can present like this. So if someone comes to you in an acute phase, they've been relatively well, sudden episode of problem, then these are the conditions to look out for. Then it's chronic psychiatric symptoms arising in childhood, not much, but it starts arising in adolescence and adulthood. That one of the main thing is you have Wilson's disease, where it's a copper metabolism disorder, and the other is Niemann-Pick type C. And I will talk about Niemann-Pick type C because Niemann-Pick disease has got actually a treatment, which is an enzyme replacement treatment now. And they can present to you in an A&E as having psychosis, and actually they've got a treatment that could cure their condition. Then you've got the late onset behavioral and personality disorders, and these are very gradual, almost personality change, almost like dementias. There are hundreds of conditions. These are the ones where there is no mental retardation. So these are individuals with normal cognitive ability who present to you with psychosis, and these conditions are often missed. And some of these conditions I've just highlighted in red, which are quite common conditions, and these, if identified, you can actually treat them. Uh, so in terms of cardiac risk, because when you're dealing with a rare disease, cardiac risk is quite high. And so in terms of cardiac risk, you obviously need to check out and see whether there's cardiac abnormalities, whether there are long QT intervals, and then you need to be able to identify whether they've got tachyarrhythmias, and you may need to start them on a beta blocker like propranolol or bisoprolol in order to keep them safe. And the most important thing is that the QTC has to be checked manually rather than what is read out, because often the reading on an ECG machine may be set for an adult ECG. So Niemann-Pick type C is a condition which is a neurodegenerative disorder which can actually lead to premature death. And it's a neurodegenerative disorder. It arises because of abnormal intracellular cholesterol metabolism, and it can present to you with neuroleptic induced dyskinesia. So you start someone on a very small dose of, let's say, aripiprazole for managing behavior, and they develop tardive dyskinesia or acute dyskinesia. The pathognomonic feature of Niemann-Pick type C is what we call a suprabulbar palsy, which means that you can move the eyes left and right. So it's a very simple thing. You just ask them to look at your finger, you're moving left to right, but you ask them to go up and down, and the eyeball cannot go up or down. So it can move left to right, but no, it cannot go up. And it's as simple as that. And that is really, if you see that, that is pseudobulbar palsy, which supranuclear gaze palsy, which actually leads to a pathognomonic diagnosis of Niemann-Pick. It's important because it can actually be treated with an enzyme replacement therapy. The enzyme replacement therapy is called miglustat. And this just tells you the same thing, that it affects at the cellular level, it damages neurons, and you've got specific parts of the brain that are being affected, especially the cerebellum, the caudate, and the prefrontal cortex. You've got neurological symptoms that arise, and death usually, and psychiatric manifestations are in terms of cognitive impairment, psychosis, bipolar, all of those things can happen. And the only thing I wanted to highlight here was that premature death often occurs because of aspiration. So the issue is, if identified, you can actually treat the condition. So let's go on to Rett syndrome. And in Rett syndrome is a condition which is an X-linked condition, which is to do with MECP2 mutation. It occurs in 1 in 10,000 live births. These are both children who have Rett syndrome and with different levels of ability. These are the necessary criteria. That is, they are normal. They've got normal prenatal and perinatal history. They are largely normal in their first 6 months. Their head circumference is normal at birth, and so on and so forth. But after that, they start losing skills, hand skills, when they are around 18 months. And then after that, they have stereotypic movements of their hands, and then they can end up having autistic-like features, and then they become dyspraxic and they can't really walk very much. They often have bruxism, they constantly teeth grind, and they have problems in breathing too. So this gives you how it progresses, the condition in age. So there's 6 months, then 1 year, and so on and so forth in years. It's normal development till around 18 months. Then there's stagnation, then microcephaly starts. Then you have autistic features until even in the ICD-10, Rett syndrome was under PDD, pervasive developmental disorder. Then you can end up having respiratory dysfunction, autonomic dysfunction, then cognitive anxiety, seizures, and so on. These individuals previously used to die because of aspiration in their 20s, but in my clinic, where I've got around 200 patients, the oldest lady I have in my clinic is around 55. So the lifespan has changed, and especially now, because there's the whole issue. There are 6 companies currently trying to develop gene therapies for this particular condition, because it's a single mutation disorder, unlike many other conditions that we've got. So This is just profile of around 100 patients in our clinic. And what it shows is that you've got motor symptoms in the most of them. You've got language difficulties. You've got autonomic symptoms. And you've got neurological symptoms, epilepsy, dystonia, and so on. The ones in red are the ones that we are targeting in the center. So we target the autonomic symptoms, the respiratory symptoms, mental health symptoms, sleep, and so on and so forth. And it's really very unique because it has changed lives of these patients, because they suddenly now have got the ability to do things that they never could do before because they've got a coordinated care pathway. So in terms of the way treatment can be done for Rett syndrome, you've got everything to do with the gene itself. Then you've got this because it's in a girl, because most of the boys die at birth itself. So you still do have a very, very small number of boys with Rett syndrome, but they're mosaic in terms of how they're present. And most of the clinical trials that have been done so far are downstream targets, which is to do with growth factors, to do with brainstem modulation, and so on and so forth. But increasingly, gene therapy has been quite successful in animal models, and the first human has already been given the gene therapy in Canada, so just last month. And so we're waiting to see how it goes. And so we will be involved in gene therapy trials very soon. So this is one of the companies, their thing. I've just taken it from their website. They're using the mitochondrial and the RNA strategy here in terms of the mRNA, how they're using a transgene, because in many of these conditions, you have to, for gene therapy, you need to have a vector. So you have the AAV virus vector. The gene, the missing gene is actually modified and put into the vector. The vector is then injected into the brain or the intrathecally, and so that it goes and populates. But the biggest problem is that it can, if you can't control the virus from multiplying and stopping when you reach the level that is needed, then you will have overshooting, and that is also dangerous and can kill. So this particular mechanism, where there are two companies that they've got RNAs, where they actually can control how much of the genetic material is being exposed, is being delivered. So this is the way forward when it comes to rare diseases. Multiple rare diseases have already got gene therapies which have been funded. This is a gene therapy thing, was a synthesis of all the information that we have on gene therapy recently, which we did, where what it boils down to is that it depends. If you want success, you need to really use it very, very young, before obvious symptoms have started. Once symptoms are there and you've already developed kyphoscoliosis, or you've developed a lot of seizures and so on, the chance of improvement is much, much less. So in an ideal world, you need to give it very, very early. The second thing is that if you've already developed symptoms, then there's another strategy that is being considered, and that is bathing the vagal nerve with the gene therapy material on the outside, so that you actually can make changes without having to go into the brain directly and inject into the brain. So this is just to tell you that when we use the automated digital clinical alerts during COVID, the rare disease patients, Rett patients, were completing the questionnaires, which are 5-minute questionnaires on a weekly basis. And what you can see here is that the fever and breathlessness followed exactly the patterns of the COVID waves that happened. And because we got to know that this was happening, because we were getting emails to say that their temperature had gone up, we could actually manage it proactively and keep them safe without them having to be admitted into hospital. This is talking about heart rate variability using wearables, where we've published on how to monitor what is happening, how much the heart rate should be when they are during the day, when they are during the night. And these can be then set up to be able to help us predict who should be given the care in order to be able to keep them safe. Again, this is just to say that you've got the electrodermal activity and the heart rate. In blue is before we treated the person with buspirone, and the red is after we treated with buspirone, and the symptoms of anxiety disappeared, and also physiologically it normalized very quickly. So when it comes to using biomarkers, we then went one step further and looked at an AI prediction modeling of Rett syndrome in girls, and we age matched girls with intellectual disability and ASD, and then tried to see whether, just using the variables data and nothing else, whether we could correctly classify them. And believe it or not, we could classify them at 97% accuracy. And that was just because the pattern of their physiological response is so different from here it is the accelerometer data, which is the red is in the orange bar and blue is the ASD girls. And you can see the electrodermal activity is very different in girls with ASD. And again, the blood volume pressure, which is the heart rate variability, is much greater in Rett syndrome compared to ASD. And therefore, we could easily classify them correctly. Now, I'm going to another condition, which is a non-genetic condition, is the anti-NMDA receptor encephalitis, which can often present with mental symptoms, psychiatric symptoms, and they can come to you with psychotic symptoms, language dysfunction, seizures, movement problems. They can end up with dyskinesia when you start treating them, and so on. So basically, where you have a prodrome phase where you may not be able to pick much up, but what happens is that the clinical worsening, as it gets more difficult, you can see initially you get agitation, psychosis, hallucinations, cognitive deficits, speech difficulties, and so on. But then after that, you can see you end up with respiratory failure and so on, neurological symptoms, and improvement is in the opposite direction. So this, the test is basically getting a blood test done to be able to look for the antibodies for the NMDA receptor. And what happens is that when you've got NMDA receptor activity is decreased, it in effect leads to dopaminergic, noradrenergic, and cholinergic systems being disrupted, leading to autonomic instability. And because it inactivates GABAergic neurons, it then affects the brainstem, which then leads to problems in breathing and cardiac things, and the person can die. So in terms of pharmacotherapy in this, you apart from the neurological medical treatment, low dose atypical antipsychotics have helped. Lithium and valproic acid use seems to help in anti-NMDA receptor encephalitis. And again, when it comes to, you have to avoid polypharmacy. In terms of mucopolysaccharidosis, there are, this again is a condition which is quite common in this part of the world. And here it's a live birth, 1 in 100,000, 50 to 100,000. They usually, the diagnosis, they're diagnosed by the time they're 3 years of age. And what happens is that their skin becomes thicker, their facial, they become dysmorphic, and then after that, speech becomes delayed, and then they become hyperactive and become almost like ADHD-like. And then as they grow older, in adolescence, they start losing skills and they become quieter and they end up being in a wheelchair. So these are conditions where there are treatments. So they've got enzyme replacement. So they are given weekly enzyme replacement to be able to manage their symptoms. It helps immensely with respect to the cardiac and the growth and liver problems, but unfortunately it does not touch the brain, and therefore the behavioral issues continue to be present and we end up having to manage them. So I'm just going to use this just to tell you that in mucopolysaccharidosis, this is Hunter's, Hurler's, Sanfilippo disease and other conditions. And what you've got is that the majority of them will have autistic symptoms, ADHD symptoms, they will have oppositional defiant disorder symptoms and other problems. So when you look at everything together, almost every child with mucopolysaccharidosis needs an assessment by a psychiatrist and needs to be helped, because they will have some of these problems, because the areas of the brain that are involved are those parts of the brain that are involved in executive function and management of the individual as such. And this just tells you that we did a study and we looked at what produced the most problems for the family, and what it was that it was not the heart problems, it was not the seizures, the parents were able to manage that, but it was the behavioral problems that was the most difficult for them to manage. And what happened was that as their behavioral problems got worse, their social support and network reduced, because people didn't want to come home, because they would actually see that there is more and more problems at home with this child. So exactly when the family needed help, they actually got less and less as such. So it's an important thing to remember that sometimes what you really have to do is manage these patients in a holistic manner and try and provide them with the support that is needed in order to get them through the crisis. So this is another study where I just wanted to show you the kind of diagnosis, which is basically ASD, ADHD, ODD. These are the main diagnoses in this group of patients. The treatment which they responded to were the same range of things, including antipsychotics in very low doses. What is really important to understand is that even though you may have a rare disease, it does not mean that symptoms cannot be managed. This is an example. When we followed them up in the first year, roughly half of them had responded to the treatment which we had provided. But then in around 3 years' time, actually the improvement had gone up to 85%. So the principle was very small doses of medication, and it had to be monitored and managed with as little polypharmacy as possible. And what is very clear is that we can actually get good improvement. So the dosages you can see here is roughly 2.5 milligram of aripiprazole was the maximum we went up to. But if you were other rare diseases, it was up to 4 milligram that we could go to. And this is the same thing in pictorial effects. So the effect size was around 1.2, which is quite impressive for a rare disease. Neuropsychiatric symptoms getting better in a rare disease where you've got a genetic condition that is underpinning the whole problem. So this is one of the cases with Sanfilippo disease where we had published the information in terms of how different symptoms get better with different medications. So this was to do with sodium valproate. When it was introduced, the mood got better, but actually the social communication didn't really get better, and that continued to get worse over time. So it is a symptomatic improvement that you can get with rare diseases. So to conclude, the issue is that you need to be looking at it from a patient-centered care. It has to be multidisciplinary. It has to be multi-specialty. You need to interact with neurologists, cardiologists, orthopedicians, spinal surgeons, everything, because without that, you cannot provide a holistic care for these individuals. Remember that a lot of them will have autonomic dysregulation, which is undiagnosed and needs to be managed. And we feel that in order to be able to provide good clinical care, you need to have a digital passport for all of these individuals, where we provide each patient with a digital passport, where we have a video clip with them when they're at their normal state, when they're having problems, and if they've got some problems, we label it, this is epilepsy, this is dystonia, and so they have it on their phone. So if there is a crisis and they go to the hospital, they can tell the doctor, please look at this video clip, which is 2 minutes first, before you make a decision what my child has got. Because otherwise, it is not, most doctors in an emergency situation do not know much about the rare diseases. They go to Dr. Google to check and see what it says, and they'll come to the conclusion that this is all to do with the rare disease. And so by actually having the video clip on their phone, it makes a huge difference, because the clinician can have a look at it and say, oh my God, this is very different from what the child looks like now. So therefore, I have to investigate and see whether the child's got sepsis, whether the child has got aspiration. These are all the common things that occur in these individuals.